Today I'm Kelly Eagen again. I'm going to present on how to manage treatment of hepatitis C when we have incomplete adherence. Um,
This is the presenter view, Kelly, sorry.
does anyone know what to do?
If you click display, yep, and then
This
swap.
one?
Yep,
Like that maybe?
perfect.
Yes,
Okay,
that's
thank
correct.
you. Thank you. Thanks for letting me know. This is our accreditation statement again. Today I'm going to be talking about strategies that can support adherence to help make it better. Review the guidelines for how to manage incomplete adherence, and then some like basic resources on retreatment. So just quick reminder is that the AASLD, which is the American Association for the Study of Liver Disease, and the IDSA, Infectious Disease Society of America. So this is liver people, infectious disease people. I always sort of joke that it's rare that two professional organizations agree, but these two organizations came together about 10 plus years ago and created a guideline on treating hepatitis C. And they very clearly, with very strong data and recommendations, say that the goal of treatment of hepatitis C is to reduce all-cause mortality and liver-related health consequences. So this is a very strong rating, the strongest you can get. And treatment is recommended for all patients with both acute and chronic hepatitis C, with the exception of people for whom have a very short life expectancy for other reasons. So, a cancer, which they are anticipate to have less than a 12-month life expectancy, we would not move forward with treating their hepatitis C. But really, other than that, everyone should be treated. We're no longer waiting until like disease progresses. We're not waiting to see if acute hepatitis C infection clears. Treatment should be sort of as soon as possible for everyone who has infection. The benefits of treatment are the reason behind why we're doing it is that we know hepatitis C treatment reduces progression to more advanced forms of liver disease and all the associated complications, including cirrhosis, end-stage liver disease, hepatocellular carcinoma. We have clear mortality benefits, reduced extrahepatic symptoms. So people, some people say like, I don't feel my hepatitis C. Well, actually, maybe you do, or maybe it's affecting your body in other ways that we have less kind of patients have less awareness of. So fatigue, dermatologic complications. The liver is responsible for glucose metabolism. And so we can see diabetes rapidly improve with cure of hepatitis C, and a variety of other complications. Also really important, especially in for this audience, if we cure hepatitis C, people can't pass it forward. So that's especially relevant for people who inject, but also we know smoke substances, as well as men who have sex with men for sexual transmission risks, and then big mortality benefits and graft survival in transplant recipients. There are simplified treatment algorithms, and I'm kind of going to leave it here for the most part. So if you go to the guidelines, there are two very straightforward simplified treatment algorithms. One is for patients without cirrhosis, and one is for patients with compensated cirrhosis. They're quite straightforward. Kind of step you through what labs should be obtained, what treatment regimens are available and appropriate, and what kind of monitoring should be done on and after treatment. For no cirrhosis, there's two pangenotypic agents, glecaprevir pembrentosvir, which is brand name Mavorite, and it's 8 weeks once a day, and then sofosbuvir valpatisvir, which is also once a day, but it's for 12 weeks. They're both great. They're both very well tolerated, and they're both very effective. For no cirrhosis, no labs are required on treatment. And really the most important thing is to get labs 12 weeks after treatment. We call it the SVR12, looking for sustained virologic response, meaning 12 weeks after treatment, your viral load should be undetectable, and that means you've been cured. That being said, it doesn't mean you like hand somebody meds and then we see them, we finish 8 to 12 weeks of treatment and then we come back 12 weeks later. Support of it that while they're on treatment is paramount. So for some people that's in-person visits, for some people that's telehealth, really depends on the individual. So this is a different case, not Maggie's case. This is a real case I had. This was 2018, so a couple years ago and then some. But this is a 49-year-old male with chronic hepatitis C, no cirrhosis. So I was like, okay, I can use the simplified treatment guidelines with severe methamphetamine use disorder, who I had started on treatment, and then he went missing. And he came back 41 days after his last dose of treatment and was like, I'm here for refills, like as if nothing had happened. And I was like, ooh, it's been 41 days. That's kind of a long time. He had already received 5 weeks of treatment. So at the time, I was working at a clinic where we could hold and store patients' meds, and they would come in and pick up Medisets or Medisets once a week, and we would dispense like a week at a time. So we knew he'd come in 5 weeks in a row and gotten 5 weeks of meds and been really consistent, and then just didn't come back week 6. So he'd gotten 5 weeks of meds, didn't come in, and then 41 days went by, and he came back, and he was like, "I'm doing so great. I need to be cured." I was like, "What do I do?" Like, oh my gosh, what do I do? This is 2018. There was no guidelines for what to do in a situation like that. So I flew by the seat of my pants. And I've also received a lot of phone calls and emails with similar cases, variations on the theme, but what do you do? And I kind of always was like taking a stab at what to do. And I love now that ASLD-IDSA provides very specific guidance on what to do. So I think before we say what actually does the guidelines say, how can we support people? You know, even if you were never a cheerleader in middle school like I was, and that's where my cheerleading career stopped, you still need to be a cheerleader for patients. Patients can do this. We're not talking about signing up for a lifelong treatment when we talk about hepatitis C. It's 8 to 12 weeks max. I think the more enthusiastic you can be that you have confidence they can do it, they will do it. Again, I say kind of only 8 to 12 weeks. Again, we're not looking to like muster up the ability to take medication every single day for the rest of one's life. I think also my experience is that patients have a really strong inherent motivation to take these meds. They've lived with hepatitis C, they've lived with fear of hepatitis C, they've lived maybe with stigma that they got hepatitis C, so they want it to be gone. So just really emphasizing, I have faith you can do this. We're here to support you. You're going to do it is like, I do believe there's power in that. I don't have data for such, but I do believe it. I would say if you're worried about adherence, have frequent touch points. That could be in person, that could be telemedicine, partnering with pharmacy or nursing staff. It doesn't have to be a prescriber calling them. It could be somebody else in the clinic. When I'm using buprenorphine for opioid use disorder, I often will pair refills. So if a patient comes once a week for a refill of the bup, the pharmacy dispense 1 week of meds at a time. So that can work. On the flip side, I don't want to like withhold the Hep C treatment, the direct DAA, direct acting antiviral. So like if it's going to be hard to come in once a week, I don't want to put that bar onto the like plate of the patient. So for some people, 4 weeks is far more realistic, and so that's okay too. But you know, think about the patient. If they're willing, if they've got a community case manager, a friend, a family member who can be helpful in reminding them to take the med, that's great. There is, you know, the simplified treatment guideline does not recommend lab monitoring while they're on treatment, though it's not unreasonable to consider doing it if you're worried about adherence. I wouldn't recommend getting a viral load sooner than 4 weeks into treatment. Viral kinetics, meaning kind of like what happens to the viral load over time. It actually probably falls very, very quickly. But if you got like a higher number 2 weeks into treatment, that's not super actionable because that might just be where we would expect it to be. But by 4 weeks of treatment, really they should be undetectable. And so if you have concerns and you think I want to get a viral load 4 weeks into treatment, you would expect it to be undetectable or very, very low. Like I would say less than 100. And can be a surrogate marker for adherence and is one strategy. So what do you do if they miss a dose? You've tried to prevent it, you're supporting them through treatment, but what do you really do? This is the question that comes up. Really what we know is we don't have good data. And at the same time, we know that people don't have they miss doses. That's the reality of everything, like all treatments for the most part. And yet we see really good cure rates. even among vulnerable populations. So this is one study, 2018. It was a study pretty small, 103 patients who had substance use histories. And they were using these electronic blister packs. So they actually got their meds in this little like electronic blister pack that could record what time they opened the dose. So it was like gave a lot of data back to the study team. 103 patients were treated and 100 completed treatment. I think that's a testament to the fact that people they take the meds and they finish treatment. A third of them were defined as non-adherence, which meant they had less than 90% adherence to the regimen. The most common patterns were just like a few days missed here and there. So like 61% of people, they knew from these blister packs that they missed 1 to 2 days at a time. About 10% had periods where they missed more than a week at a time. And yet all of this, the SVR was the same between the adherent and the quote non-adherent, which was like less than 90% adherence and still 94%. So this is like really good data. Again, small study, and really the data says we just don't have good data about like how much is too much to miss. I don't tell people like, oh, you don't need to take it all. Like it's fine if you miss some, but I also like sort of say like if you miss it, just keep going. Just keep going. Like you miss a day, just take it late, take it the next day, and just finish it off. Because we know that these are really potent and powerful meds. But actually, the good news is you don't need to just fly by the seat of your pants anymore. There's guidelines that tell you very concretely what to do. So the AASLD guidelines break populations into basically what happens if you're missing doses in the first 28 days versus the second 28 to, the second month or two, depending if you have an 8 or a 12-week course. And then they say, okay, so if you're in the first 28 days and you miss less than 7 days, what do you do? So this is this like first box on the left, missed less than 7 days. It's easy. Just restart and keep taking it. Just finish it off. Just keep chugging away, like I said. If you miss more than 8 days, you also just keep taking it. But ideally, you can have the person come in, get a viral load, and use the result of that viral load to guide if you need to extend treatment. And so if they miss more than 8 days and you get a viral load, if it's undetectable, like if it's very, very low, less than 25 IU per liter, you just finish treatment off as if nothing happened. If it's more than that, so if it's basically comes back with a number, then they recommend you extend treatment by an additional 4 weeks. So you just tack on an additional 4 weeks. If we move to the right side of this table or this image, if treatment interruptions happen in month 2 or beyond, again, less than 7 days, just chug ahead, just start it up again and keep going. If you fall in kind of the 8 to 20 day window, again, just as soon as you can, start taking meds again. Similarly, get a viral load, and then depending on the results of the viral load, the guideline tells you what to do. If they miss more than 21 days and it's in like the second or later month of treatment, they just say stop, don't restart. Get a viral load. If it's undetectable, congratulations, you were cured. If it's not undetectable, then you will retreat them down the road. So it's very prescriptive, and I don't have it memorized, but it exists on the guidelines, which I have a resource at the end of this presentation for. And so it's really easy now. We kind of just go to the guidelines when this happens. I think there is an inherent question of like, what if they're like missing 3 days every 2 weeks, like every week? I think, again, that gets back to this is not a well-studied topic, but I would just kind of be true to these guidelines and just like keep, if they're missing 1 to 2 days at a time, they really just need to finish off the course of treatment. But it's nice that now there are guidelines, so we don't need to kind of just like use our best guess. So my patient, again, going back to this gentleman, he had received 5 weeks of treatment and he then missed 41 days. I didn't have any guidelines, so I didn't know what to do. So the guideline says if we go to I took a screenshot of the guideline for this and tried to apply it to this individual. So the guideline would actually say he's in the second month of treatment. He's already finished 5 weeks and he missed 41 days. So he's that bottom box, which says stop. You're done. You've missed so much. You're done. Get an SVR 12 or get an SVR. And if it's undetectable, great. If it's not, then you're going to be somebody who gets retreated in the future. What did I do? I think you can see that. So what did I actually do? I didn't have any guidelines, and I was like, oh, I don't know, I want you to be treated. So I kind of did what the guidelines suggest. I restarted him I didn't. I restarted him right away, and I sent a viral load that day. And it came back a couple days later as undetectable. So I said, great, let's finish off treatment. He was cured. That's great. I think the implication here is if I had had the guidelines, I wouldn't have restarted him on treatment. So ultimately, this specific individual probably got more than he needed. He was cured. He probably would have been cured anyways, even if I never restarted, but I kind of took my best guess knowing what I thought at the time. So let's say same guy, he took 5 weeks of treatment. What if he was only gone for 15 days? So not 41, which is pretty long. Say he was only missed 15 days of treatment. You then find yourself in the middle box on this diagram. So they say restart treatment. So restart it right away. The day the patient contacts you, say, oh, just start taking it. Go to the pharmacy. You'll get your refill. Start taking it. Come into the clinic. Send a viral load. If it's undetectable, then just complete as planned. If it's detected, you kind of follow the algorithm there to decide what to do. I'm going to change the case just one bit more. What if he had only taken 10 days of treatment? So then if you think back to the original diagram I showed you, there was 2 arms within the first month or within the second month. So if the interruption happens in the first 28 days of treatment, the guidance is a little different. But again, it's pretty straightforward. You just kind of like find your box on the diagram based on what has happened clinically, and it's very clear what to do. So if it happens in the first month, again, the answer always is just like, unless they're in the second month and they've been gone more than 21 days, the most important thing is to get meds in hand and have them start taking it again as quickly as possible. And then maybe send a viral load depending on where you are sort of in the scenario. So this again is that entire image for reference, and this is all available online. I wanted to call out something that's more recently come out in the literature and I think is really relevant in our population, which is one of the things that's very difficult is people, you cheerlead, you encourage everybody to take the meds, and they do. Yeah, they do really well. They finish it. Like, in that study I shared, 100 out of 103 people completed treatment. They're going to complete it. I think that's my most common experience. But then you say, oh, congrats, you took it. I'm sure the meds were so effective. Great for you. But then they don't come back 12 weeks later for the SVR12. And so you're never able to get that lab value to confirm they were cured. It doesn't change what happened within their own body. They were or were not cured, but we have no lab data to confirm. And that's also relevant because what happens 2 years from now if suddenly they resurface and have a detectable viral load? We have no way of knowing, were they cured or were they reinfected, or did they have a treatment failure? And so getting a viral load RNA after completion of treatment is really important because it's going to help with the assessment down the road if ever there's a concern for reinfection versus treatment failure. And yet it's really hard to track people down 12 weeks after treatment. So this is a study that looked at, can we assess cure earlier? And so what they did was they looked at a population of people who were injecting drugs and who completed treatment with the simplified treatment guidelines. And they said, can we try to correlate if they completed treatment, does that predict cure? And if they get a SVR4, so 4 weeks after treatment, does that correlate with an SVR12 if we can get it? And what they found was that for people who completed treatment and were successful at completing treatment, that had a 96.6% positive predictive value that they would in fact be cured at SVR12. So that's really great. So we know that if they, and 100% negative predictive value. So if they complete treatment, that in and of itself is very helpful information. So even just knowing they completed treatment, 96.6% of the time, that's going to correlate to their SVR12 results. And so for like this guy that Maggie presented, he reports completing treatment. So it makes me more inclined to think that it was a reinfection, but we don't know. And then if you can get somebody in for an SVR4, it was 100% positive predictive value and 100% negative predictive value for what the SVR12 result was. So I think the actionable item to take away from this study is you might consider getting an RNA when they finish treatment or at least 4 weeks after treatment, because those values have very high positive predictive values for cure, and it's far easier to get that lab earlier rather than later for many patients. So some guidelines are starting to call out consideration of SVR4 as a surrogate marker for cure rather than SVR12, which has been the gold standard. So if you're faced in the situation where somebody isn't cured, so at whatever time frame after they complete treatment, their viral load is elevated again, we think about retreatment. Really inherent to this is an assessment of, was this a reinfection or a treatment failure? So like in talking to the patient, again, as Sheila pointed out, like doing so in a way that is not accusatory, is not putting the patient in a position where they like have guilt or feel like they can't disclose how things actually happened. So reviewing adherence, how good was the adherence? Did they complete treatment? Other factors that might have happened during the course of treatment. Do you have data? Do you have an SVR12? Do you have an SVR4? Do you have some other random viral load around that time? Asking them about reinfection risks. So that's not just injection, but it's smoking supplies, sexual risks, and other household items. And then comparing genotypes. So if we go back to the simplified treatment guidelines, they actually don't recommend getting a genotype because the medications we use are pangenotypic, meaning it doesn't matter what your genotype is. However, if they had a genotype that showed one genotype, like say they were genotype 1, and then down the road, they're genotype 2, that is highly suggestive that actually this is a reinfection with a different genotype. But the reality is a lot of patients don't have genotypes on file, and also genotype 1 is the most common in our country, and so a lot of times, even if it's a reinfection, they get reinfected with the same genotype, so we don't really know. But it is one more sort of thing you can consider if that's available. If you know definitively that they were reinfected, then it's easy. You just treat them as if it's a new infection because it is a new infection. You don't have to worry about like baseline resistance or anything like that. But if you're treating them as a treatment failure, again, good news, there are guidelines for this. And actually, as I like dug into this, I was a little surprised to understand and learn, and I talked to some colleagues to corroborate my understanding, that in fact, we're not doing as much resistance testing anymore as I think we did much earlier on in the use of direct-acting antivirals, because so resistance is this idea that the virus has mutated and the medications are not as effective in treating the virus. And so some viruses inherently have resistance mutations and others develop resistance when exposed to antivirals. And so if they've been treated and they develop resistance on treatment, down the road, they might then have resistance and need a different agent. But this has been like studied pretty extensively now. And we know that having received direct-acting antivirals in the past might select for, that means kind of lead to viruses that have mutations. We call them resistance associated substitution, RAS, So like if they've been exposed to direct-acting antivirals and they have resistance, like the resistant virus is going to be the one that thrives. And so these RASes tend to thrive in the setting of receiving antivirals. However, they don't have an impact on the efficacy of retreatment if you retreat with a 3-drug regimen. So, when we talk about initial treatment, we're talking about like Mavorite has 2 drugs in it, glucopirazvir and pembrolizumab, 2 drugs combined into one pill, but it's only 2 drugs. Epclusa, which is sofosbuvir, valproatisvir, 2 drugs. So initial treatment regimen uses 2 drugs combined into a single pill. Retreatment hinges on using 3 drugs combined into a regimen. And we know that even if there's resistance, as long as you use 3 drugs, it doesn't really matter. So the guidelines actually don't recommend resistance testing for initial retreatment. Now, if they've had multiple rounds of treatment, that's a whole nother story. Then we definitely need resistance testing. And there are some caveats for people with genotype 3 and cirrhosis. Genotype 3 is notoriously harder to treat, and patients who have cirrhosis, it's a bit harder to treat. But actually, there's so the top box, and this is not sort of to take away to know how to retreat from this talk, but I just want to share that there are very clear guidelines on how you can retreat people if they've been treated once and it didn't work. Very clear guidance on what to treat with the second time around, and it depends on, did they get like a Mavorite regimen, or did they get a regimen that included sofosbuvir? So, I mean, again, like it's okay to phone a friend, call our hotline, talk to a hepatologist or an infectious disease specialist. By all means, don't do something that's uncomfortable. But also, the guidelines do have some guidelines or guidance for this as well. And so I wanted to call that out. So I think take homes, really back to the basics, screen the patients you take care of for Hep C. Screen them frequently if they have ongoing risks. Absolutely treat them. Like a fear of non-adherence should never stop you from treating somebody. I mean, if you know they're basically not going to take the medication, that's another story. But this fear that maybe they're going to miss a dose here or there or not have perfect adherence, just treat them. And there's great guidance now on what to do if they do miss. I think in my practice, I'm definitely going to start trying to get an SVR4. If they're still around for an SVR12, great, I'll get that too, but definitely getting an SVR4. And then if somebody fails treatment, we can retreat them. And most importantly, you can do this, and actually I think you should, but you can do it. If you're not doing it already, by all means, reach out to talk about how we can support you to be incorporating this into practice. I think that's my last slide. Oh, here are some resources. And I open it up for questions.
Hey, Kelly.
Hi.
I'm trying to remember if we talked about there's been no luck getting this therapy started in the inpatient setting. Is that right?
Yeah, correct. We've done a lot of investigation about doing it in the hospital. Haven't been able to get it because of formulary restrictions, but we have like what we're trying to do is kind of get all the labs or workup, so to speak, and then discharge somebody with a bag with 28 days and a plan for follow-up. So we can discharge them with the first month of treatment.
Okay, gotcha.
Yeah. Yeah. And yeah, there's been some small studies looking at is hospitalization I mean, if they're going to be in the hospital for the majority of their treatment course, ideally you treat them in the hospital, but actually there's some like coverage limitations there. Some people get around it in creative ways, but not at our institution. We haven't been able to. But there's also some data that shows that like even just like starting treatment at discharge, like I think it's a captive moment and people have good completion rates. So I would just say don't be scared of non-adherence. Don't be scared of it just works. The meds work, and increasingly there's lots of data data to drive what to do if doses are missed, somebody needs to be retreated, and that's been an evolution from 5+ years ago when we kind of were just like, oh, take your best guess and keep going or stop. But I think increasingly we know that population of people who use substances are one of our top priorities of people to be treated, and the treatment is effective for them. So that's my takeaway. And there was a slide early on about the provider consultation line that our team offers. And we are happy to field questions about hepatitis C management. And, we will admittedly let you know when we need, when we think, oh, that's would be a great question for a hepatologist or something like that. So if you ever have a question, feel free to reach out via our consult line, and we can provide answers or get more information or put you in touch with somebody who can provide some more guidance. Because we recognize these questions come up among addiction medicine providers and people in primary care, and sending patients to a specialist is often not the best way for them to get treated. Or it's not necessary, I should say. Okay, well, we coming to the end. Again, next month, excuse me, March, we're going to have Dr. Max Butler presenting on kratom and treatment. So have a great end of February, beginning of March. We are always looking for cases. If anyone has any cases they want to share at ECHO, reach out to Nada or Dr. Lineweber or myself, and we can kind of coordinate getting you on the schedule for a future session.